Sir, now we are live. With all your permission, I'm starting this session.
Yes.
Good evening, everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, Professor Dr. Vitul K. Gupta, sir. Sir has done MD in Medicine, FICP, FCSI, FSCP, FIACM, Health and Human Rights Activist, Honorary Teaching Faculty AIMS, Bhatinda, and consultant at Kishori Ram Hospital and Diabetes Care Center, Kishori Ram Road, Basant Vihar, Bhatinda, Punjab. Today, sir is going to discuss on a topic, challenges in diabetes education. Let me tell you overview of the topic. With more than 77 million diabetic patients in India and being higher number of undiagnosed cases, the lack of qualified diabetes educators, awareness, accessibility, and availability of structured diabetes education programs poses a bigger challenge for both diabetes care and education. To get better understand and learn about possible solution for the challenges in diabetes, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Yeah, thank you very much. So I must compliment IJCP platform for giving me an opportunity to talk about challenges in diabetes education. So basically, I feel that in India, with decreased or less infrastructure, education in health affairs gains importance which is larger than life. So with all the constraints, if we have education, that patients or the general public is educated about non-communicable diseases or health issues, we can fare much better. So I will be talking today the challenges in diabetes education, especially in Indian context. Next slide. Next. So I start the lecture with paying tributes to my late father, Comrade Ved Prakash Gupta, and my friend, mentor, and senior, Dr. Gurpreet Singh Wander, because what I am today is because of basically contribution by these two personalities. Next. Thanks to my family for all the support. Next. So coming on to the topic, India faces a huge burden of diabetes and its complications. Over half the Indian population is at risk of developing diabetes at some point of time in their lives. So that is a huge number. Urban India is more likely to develop diabetes than ever before, and rural India is also fast catching up. So there is increased prevalence as well as risk of diabetes, or you can say non-communicable diseases in urban India, and rural India has less prevalence. But with urbanization of rural areas, increasing NCDs are being felt in rural population also. Next. So in India, more than 77 million adults are living with diabetes. Research predicts that this will increase to 134 million by 2045. So that is almost about double the population prevalence. Estimates that 57% of the cases remain undiagnosed and increasing risk of serious complications. So because diabetes is a serious problem with grave complications, so if 57% remain undiagnosed, you can assess, you can estimate the burden of complications which we can have in India. Next. Challenges in diabetes care in India, if we want to enumerate, they can be rising prevalence in urban as well as in rural areas, high prevalence of pre-diabetes, genetic and environmental risk factors, rising prevalence among young people, delayed diagnosis. Next. Low disease awareness among the public and low disease awareness among the healthcare providers. So these are the two main focus if we are going to enumerate the challenges in diabetes education. Unlimited healthcare facilities, limited healthcare facilities, high cost of disease management, suboptimal diabetes control, and rising rate of diabetes complications. So these are the challenges faced by the diabetes care in India, out of which I have marked in red, that is low disease awareness among both public as well as the healthcare professionals. Next. So India is now the diabetes capital of the world, and most serious challenges we face today are lack of general awareness about diabetes, rapid lifestyle transition. We are going in for rapid lifestyle transition more towards increasing prevalence of non-communicable diseases, narrowing urban-rural divide, and most effective solution, what I think or what the public health activists think, is creating awareness for prevention and control of diabetes. So basically, this line gains importance because if we treat diabetes, we are not going to decrease the burden of diabetes and eliminating the title of diabetes capital of the world from the Indian subcontinent. Just by creating awareness, which is of prime importance in prevention as well as control of diabetes. So if we prevent diabetes, only then the prevalence of diabetes will decrease. And for that, creating awareness is the most effective solution. That is why this lecture gains importance to prevent diabetes. Next. Next slide, please. So lack of diabetes education and awareness is leading to. So what we are talking, why we are talking that awareness is very important? Because lack of awareness leads to increased prevalence of diabetes because of unfavorable lifestyle, delayed diagnosis because of lack of awareness about symptoms, fewer people have controlled diabetes, increasing complications such as amputation, stroke, the chronic kidney disease and blindness, etc. These are all increasing because of lack of diabetes education. Next. So only diabetes education and awareness can arrest the march of diabetes epidemic. So this is what diabetes epidemic look like. So these pictures you can see on cigarette packs, but now the NCDs are also posing a great threat to humanity. Next. Challenges in diabetes education, that is low awareness level, huge population, huge number of people with diabetes, deficient healthcare infrastructure, deficient qualified manpower of healthcare professionals, socioeconomic considerations, faith in alternative system of treatment. So these are a few factors which pose challenges in diabetes education. Next. Diabetes self-management education is globally recognized integral part of diabetes management, practiced by developed countries through trained diabetes educators. Unfortunately, in India, it is still not considered as an essential part of diabetes management. Sadly, cadre of diabetes educators are virtually non-existent in India and may be available only in five-star hospitals, in metro cities. A few corporate hospitals may have diabetes educators, but generally you won't have heard about diabetes educators. Next. Evidence show awareness and knowledge about diabetes is grossly inadequate in India. A massive diabetes education program are urgently needed at national level. The National Diabetes Educator Program, initiated in 2011, was first structured education program for diabetes educators in India. Still, the number of diabetes educators are grossly inadequate and the huge diabetes population of India. Next. So diabetes awareness and you combat the silent killer. So this should be the motto of all the people involved in diabetes care or non-communicable diseases, to create awareness about the non-communicable diseases. Next. So for common people, on an average, people with diabetes spend only 3 hours a year with a healthcare professional. So the person is spending only 3 hours every year, and for remaining hours, they manage their diabetes themselves, for which they are unaware. So they cannot manage the diabetes properly. A population-based study reported that 41% were not aware of adverse health effects of diabetes. 30% knew about complication related to diabetes. That means 70% did not know the complications related to diabetes. 46% felt that it was a temporary phenomenon. Next. The Curious study reported that 25% of population was unaware of diabetes disease as such. About 40% felt that diabetes was increasing. About 22% people felt that diabetes could be prevented. 41% of diabetics felt that diabetes could be prevented. About 11% knew obesity and physical inactivity as risk factors of diabetes. That means rest 89% did not knew that obesity and physical inactivity are risk factors for diabetes. About 40% diabetics were aware of organ damage by diabetes mellitus. Next. So another studies, or many studies, report about 60% are unaware of risk factors, 60% are unaware of complications, 50% patients are unaware that good glycemic control would help to avoid complications. Only about 7% patients were aware of HbA1c testing for diagnosis of diabetes. Only about 10% of patients reported receiving diabetes self-management education. Next. Only 43% of overall study population of about 15,000 had heard about a condition called diabetes. About them, there were more males than females. About 58% urban residents had higher awareness of rates than the rural residents. So this shows that urban people are more aware about the disease than rural population. Among common people, Tamil Nadu has highest, that is 31%, and Jharkhand has lowest score, that is 16%. Among diabetes subjects, Maharashtra had the highest and Tamil Nadu has the lowest score. Next. So previous few slides have told us that there is lack of awareness about diabetes, every aspect of diabetes, about diagnosis, about complications among the common people. And if we consider awareness among healthcare professionals, there is lack of education about diabetes may also be common among medical professionals. Lack of understanding for need of constant monitoring and consistent tight glycemic control in patients. So these are the two areas where the awareness may be lacking among the healthcare professionals, that is constant monitoring and consistent tight glycemic control. In a study, about 33% healthcare professionals in some countries reported lack of formal diabetes training. Next. Low level of awareness of diabetes among physicians result in poor glycemic control in Indian patients. Other important aspect is lack of awareness amongst physicians also impacts the use of insulin. The practitioners prescribe alternative or traditional therapies or oral anti-diabetic drugs for diabetes care to retain patients or due to lack of proper information. Use of insulin therapy as a last resort for disease management. So generally there is tendency among the patients to avoid insulin कि हमने इंजेक्शन नहीं लगवाना है, कोई और दवाई बता दीजिए. So and physicians with the fear of losing the patients may try to continue with oral drugs or alternative therapies instead of giving insulin or educating the people for taking insulin for diabetes control, leading to worsening of diabetes and increased complications among the patients. Next. General physicians and family doctors are responsible for delay in insulin therapy due to their suboptimal knowledge and attitudinal issues, poor referral to endocrinologists, lack of patient counseling, suboptimal care impede the effectiveness and efficiency of patients' care in India. Primary care physicians getting certified as diabetologists at low-level universities and colleges provide substandard care. So this is very important. Every doctor can write a diabetologist without a certified degree or qualification, and that can eventually lead to substandard care of diabetes. Next. So what is the way forward? So my dear friends, way forward lies in diabetes awareness. So generating awareness about diabetes is of prime importance, and that is the only way forward for prevention and control of diabetes. Next. So there is urgent need for education and awareness about diabetes among the general population, among the diabetic population, as well as healthcare professionals. So these are the three groups where the general population includes everyone, in fact. Next slide. So the goals of diabetes education should be prevention and control, that is providing knowledge and skills, changing the patient's behavior, motivation to comply with recommendations, improving the quality of life, and most importantly, that is why I have marked this in red, establishing a partnership with the family and healthcare professionals. So if there is emotional, the conditional, as well as there is a bond, then the healthcare professionals may be able to convince the patient along with their family members for good control and prevention as well as care of diabetes. Preparing for self-care, increasing awareness of risk factors, increasing psychological resilience. So these are the important goals of diabetes education program. Next. Food patterns appropriate to the individual needs, regular physical activity, regular monitoring of blood glucose, pharmacological adherence, following the doctor's instructions, knowledge about acute problems. So that is hypoglycemia as well as hyperglycemia is very, very important. Psychosocial adaptation, motivation to achievement, risk reduction of common chronic complications. Next. So components of effective diabetes awareness program, as we have already discussed, that is strategies for general population. If we think general population are to be made aware, so we have a different strategies for general population, strategies for diabetic patients, and strategies for healthcare professionals. So these are the components for effective diabetes awareness program. Next. Strategies for general population and diabetes patients can be combined together because it will be difficult to separate a diabetes education program for general population as well as diabetic patients. So that requires a huge outlay of resources and efforts to succeed because we have a huge general population and diabetic population also. So we can use multiple modes of communication. Conventional modes of communications can be used like dramas, skit, newspapers, the TV, etc. Modern non-conventional modes of communications are proving to be now more effective. Use of internet, short message service, mobile phone apps, etc. can be used. Next. Community involvement is a must. So we can have community awareness program where we can talk to a lot of people together. Telemedicine based multidisciplinary care, because in India resource constraints are there. So telemedicine can be used to consult various stakeholders for awareness program. Popular figures and community leaders can be effective in communicating the message. Public private partnership program, there can be, private hospitals can be involved by the government for awareness program roles. Pivotal role of media helps in dissemination of accurate information. So this is real important. Because of the role of media, you can have fake news, misinformation, which is leading to the low level of diabetes care, and misinformation can be very detrimental. Identification of high risk groups and role of professional associations like RSSDI, DIPSI, API, etc. Diabetes groups are real important. Next. So educational and awareness programs must be simultaneously planned for various stakeholders in diabetes management. Uniformity of content to assure consistency of information across various levels of care. So again, I will stress on uniformity of content. So pan India, the diabetes awareness should have a uniformity of content, whether we are educating the people in Tamil Nadu or in Punjab. The education material should be same in different languages, certainly. Multi-stakeholder participation, broad consensus of opinion recommendation endorsed by national level organizations, which I have already enumerated in the previous slide. Next. Multi-level synergistic partnership between government and private sector, because in India about majority of the patients go to private sector and government is mostly focusing on preventive health care. So there should be a intense or great partnership between the government and private sector. Only then we can generate the awareness about the non-communicable diseases and diabetes in particular. Integrated diabetes education across all levels of healthcare professionals, from the student onwards. We should focus now on the non-communicable diseases. Family-centric education program to involve the most important stakeholders who bear a significant burden of disease indirectly. So if a family member is a diabetic, we can involve the whole of the family into the education program, because ultimately, because of that diabetic patient, the family members are going to suffer. Easy and comprehensible information, communication for very simple day-to-day strategies. So if we have complicated strategies, complicated awareness program, the patients may not follow. So we must have a very simple everyday strategies for the population. Next. Specialized diabetes educators. So again, this is a far-fetched dream, because we still don't have sufficient doctors to treat our Indian population. So we are still hoping for specialized diabetes educators. Socio-cultural factors and strength prevalent in society must be incorporated in the curricula to enable those with diabetes to become advocate for primary prevention within their families and communities. So we can make diabetes patients as leaders, and they can share their experiences as well as control of diabetes, because that will effectively percolate the message about prevention of diabetes among population. The curricula should create an effective balance between intellectual appeal and practical usefulness to cater to this diverse group, especially the diverse group of high risk group, as well as the diabetes population. Next. So education and awareness is one of the key components for prevention and holistic management of diabetes and its complications. Currently, health education to prevent diabetes in rural India is almost non-existent, and there are great myths about diabetes or non-communicable diseases, especially in rural areas. Major gaps exist in education about health and nutrition. Awareness about lifestyle factors for non-communicable diseases is also unsatisfactory. Next. However, knowledge alone is insufficient to bring about behavioral change, and patients' health attitudes and personal barriers to diabetes care are influenced by social, cultural, socio-economic, and healthcare system factors. And I feel in India, economic factors are very, very important because most of the people can't afford treatment. And there, again, awareness will definitely help, but we must provide the care at public care institutions. Identification of underlying reasons for variation in attitudes and behavior is increasingly being recognized as an essential element for designing and evaluating diabetes education program. Next. So, my dear friends, from the previous slides, what is the take-home message? The message is very clear. There is urgent need for a vibrant education and awareness program in India for diverse journal as well as diabetes population, for which I may add here that for non-communicable disease population as well as stressing on high risk so that we can prevent non-communicable diseases. Identifying key strengths and weaknesses associated with socio-cultural economic factors should be incorporated in program engaging all health professionals in imparting diabetes education. In all health professionals, I mean the government as well as the private sector. National Program for Prevention and Control of NCDs offer an opportunity for improving care at primary and secondary level. So it is very welcome step that India has initiated National Program for Prevention and Control of Non-Communicable Diseases, which provide opportunities for improved care. Next. Socioeconomic, educational, cultural, and language barriers pose a significant challenge in the implementation of an effective program. Diabetes education is a dynamic and ever-changing field, and diabetes educators need to respond to these changes in practice. Role of diabetes educator is therefore crucial in disease management process. So if there are no diabetes educator, a healthcare professional can adopt the role of diabetes educator and can spend 3 to 5 minutes educating the high risk group or diabetes patients about diabetes and its prevention, control, and management. Next. So diabetes is challenges in diabetes education are numerous, but that should not discourage us, but strengthen our resolve to do whatever is possible under given circumstances. So I think we should not wait for more diabetes educators in our system, and we should start diabetes education today. Whatever a little bit time we can provide, and we should take the opportunity to educate the persons, the whole population, high risk groups, and especially diabetics, and we should start it from today. Next. So a few people are, are involved in diabetes education. So it is RSSDI as well as Diabetes India, which is led by, next slide, 3 people I must mention who are leading figures in diabetes education program and in control of diabetes in India. That is Dr. Bansi Sabu, who is RSSDI president, Dr. Sunil Gupta, he's initiating a great diabetes program, and Dr. V. Mohan, who is pioneer in all the diabetes research as well as new concepts in India. So these are the torch bearers, so which I think they are my role models for diabetes education and diabetes care program in India. Next. So thank you very much. For this, I invite you all for 10th Annual Conference of Association of Physicians of India, MAPICON 2023, being organized from 21st to 24th September 2023 at Hotel Sapal Bathinda, for which we have applied for 16 credit hours from Punjab Medical Council. Thank you very much.
Thank you so much, sir, for taking out your precious time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participant doctors on their practice also. Sir, as I can see, sir, we have received some questions from the participant. With all your permission, can we take these questions?
Yes, definitely.
Yeah, the first question is modified plate method suitable for all type 2 DM patients?
What modified?
A modified plate method suitable for all type 2 diabetes mellitus
No, basically you
patients.
must understand there is no one fit all patients. So every patient has their nutritional needs depending upon body mass index, whether it is high, it is obese, morbidly obese, thin, malnourished. So that is how you can modify the diet according to the glycemic index, taking out the diet. So tailor-made dietary program. So we can say the diet chart with basic focus on the contents, that is WHO determined balanced diet accordingly. So this is not all fit single diet program for all the patients.
Okay, thank you so much for explaining it, sir. Moving forward, I can see there is another question. The question is, in management of diabetes in hospitalized patient, the oral agents have any indications or always are contraindicated?
No, basically we are talking about diabetes education now. We are not talking about diabetes management. Again, in hospitalized patients, we can assess if there is need for insulin, like patients of myocardial infarction is there and diabetes is not controlled, we have to give insulin and control diabetes. But if the patient of myocardial infarction already diabetes is controlled, patient is already on OHAs, so we can continue the OHAs in that hospitalized patient. So again, we have to assess the patient individually, whether the hospitalized patient is in coma, is what is the GCS. So accordingly, we can give insulin or oral hypoglycemic agents.
Okay, thank you so much, sir, for explaining it really well, sir. I can see there is couple of questions. We will be taking last two questions for today's session. And the question is there any association of personality traits with genesis of type 2 diabetes?
No.
Okay, thank you so much, sir. And the last question is, to what extent do you think healthcare providers can implement and target diabetes education sessions for children under 16 years and their parents?
Very good question. So basically, that is the group which should be targeted for prevention of diabetes. If we can target the group from 8 to 16 years, so that is the group where the health education program can be very, very effective. So we are initiating a program called Catch Them Young. So that is less than 18 years of people, the population should be made aware of good health practices so we can have a healthy population.
Okay, thank you so much, sir, for answering all the questions really well. As I can see, there is no more question from the participant end. As there is no more questions, sir, with all your permission, shall we conclude this session?
Yes. Thank you
Yeah,
very
thank you
much.
so much. Yeah, welcome, sir. And till then, take care of yourself and hope to see you again with different topics, sir. And thank